So good morning, everybody. I'm Dr. Rama Kalantri from Pune, and I shall be sharing my initial experience of managing monocular elevation deficiency, that is MED, of various etiologies. I don't have any financial disclosure. So MED is a unilateral defect of upgaze with ipsilateral ptosis. The causes could be congenital, which could be due to supranuclear defects, primary superior rectus paresis, or inferior rectus restriction, or they could be acquired due to cerebrovascular diseases, midbrain tumors, or sarcoidosis. So my first patient was a 24-year-old male who presented with drooping of the right upper eyelid and outward deviation of either eye since birth. On alternate prism cover test, he measured 45 prism diopters of L over R with 30 prism diopters of exotropia. So diagnosis of right-sided MED was made. He was planned to undergo stage strabismus surgery followed by ptosis correction. The force reduction test was negative for inferior rectus, and hence augmented NAPS procedure was planned in the right eye. At 3 months of follow-up, he measured 25 prism diopters of L over R with 30 prism diopters of exotropia on APCT with slightly improved elevation. This patient awaits next surgery. The second patient was an 8-year-old boy who presented with drooping of the right upper lid since 2 months of age following dog bite over the right periorbital area. On modified Krimsky, he measured 35 prism diopters of L over R. This boy was amblyopic in the right eye with hyperopic astigmatism, and his best corrected visual acuity was 6/36. The CT scan of orbits showed displaced fracture of the superolateral wall of the right orbit opposing the right lobe. So the plan was to perform strabismus surgery in a staged manner as required, followed by ptosis correction. Again, the FDT was negative for inferior rectus, and augmented NAPS procedure was performed in his right eye. At 6 months of follow-up, he measured 16 prism diopters of L over R with modified Krimsky, and then the parents of the patient were not further interested in the surgical correction for strabismus, and hence they underwent the further ptosis correction at 9 months after the first surgery, which was LPS resection in the right eye. This is how he looked after 1 month of ptosis correction. So ocular injuries reported due to dog bite include lid lacerations, canalicular avulsion, ptosis from levator transaction, facial nerve damage, medial rectus rupture, and orbital fractures. There is also a case of isolated superior rectus injury by dog bite, which was managed by NAP procedure, but it did not present with ptosis. In conclusion, the etiologies in both the above cases were different, one being congenital and the other post-traumatic following a dog bite, which itself is a rare case. However, since both presented like MED without inferior rectus restriction, both were managed by augmented NAPS procedure. Thank you.
Yeah, thanks for sharing those two cases. So what is the new thing you want to add here? I mean, other than, the mode of injury, which you found to be rare, which is not.
Yes, sir. So yes, first thing, the congenital ones are most commonly, which we generally come up with. And this, the second patient was a different etiology. Actually, so this was the initial, this experience was like the first year of my clinical practice in which I saw these two cases. So I thought I could just present my experience.
Yeah, so what was the duration, like when they presented to you? Because, the IR tightness at such an early presentation would be very unlikely until and unless, it's a long standing, and then, even if it is superior rectus palsy, over a period of time, the antagonist would go into a contracture. So there, if they present later, then probably you need to, touch the inferior rectus, along with definitely, the transposition of nowadays, like either MR or LR to SR with modification suture. So what was the duration when they presented to you? Because otherwise you would get IR, on FDT, it will not be tight.
Yes, so sir. Somehow with both the patients, the IR was not very tight. Now this patient with congenital MED had presented at 24 years of age for the first time. And the other one had this injury, and then he was an 8-year-old while he presented.
So again,
almost,
what was the long duration? what was the elevation limitation in this first and second case?
So the elevation is restriction was like I showed in the pictures. Like you want the exact number?
Yeah, I mean, was it like -4, -3?
So -3 is somewhere. Good, sir. Almost both.
Okay. Yeah, because usually when the IR is not tight, then I would anticipate more gross elevation limitation, like not crossing even midline, -4 or worse than that. If at all, it's a supranuclear palsy. But if you look at the literature, even in supranuclear palsies, over a period of time, IR becomes tight, and that is how the standard approach for this patient is on table FDT on IR and then take a
Yes, sir.
call. So we
Yes, sir.
do
Both the
find
patients,
tightness
yes,
with
sir.
this.
Both the FDTs were done on table, and it was not such a very gross restriction of the inferior rectus.
You need to also talk about like the ptosis, whether it is true ptosis, pseudotosis, and whether that is associated with the Bell's phenomenon. How's the
Yes,
Bell's?
sir.
All those factors are very, very important to take a surgical decision and ultimate outcome.
Yes, sir.
That's nice.